So welcome everybody. Welcome to the EANS webinar. I'm very happy. My name is Jürgen Beck. I'm the Director of Neurosurgery in Freiburg. And I'm very happy to have two special guests here today. And we have a wonderful topic. The topic is CSF-venous fistulas, very timely topic. And with two questions, how do I find them and how are they treated? For you, the audience, please remember that you are very well allowed and engaged to ask questions. Please type in your questions in the Q&A box, not in the chat box, in the Q&A box. And we really try to make room for discussions in between the talks and then for a broader discussion at the end of both talks. Let me introduce Thomas Dobrodsky briefly. He is a neuroradiologist, an interventional neuroradiologist from the Inselspital in Bern, Switzerland. And he is a senior physician there. And since 2018, he has specialized in the field of interventional neuroradiology, is very active in stroke treatment, has a huge research program, and did also fellowships at the Toronto Western Hospital with Timo Krings and Vitor Pereira, as well as in the Fondation Rothschild in Paris with Michel Piotin. And he's not only an expert in endovascular treatment of stroke and tiny little perforating arteries now, but also by heart, and he really loves CSF disorders. And for you that don't know, I worked together. I was lucky to working together with Thomas Dobrodsky at my time in Bern. And we did a lot of research. And with his enthusiasm, he was leading the group when we made the brain score, that is now the Bern score, internationally accepted as the Bern score. And I'm very happy that he is giving a little short introduction and then an overview from the interventional neurology point of view about CSF venous fistula. Thomas, please start your presentation.
So I think you should be able to see my presentation, if that's correct. So thank you very much for the kind introduction. It's a pleasure being able to join this special group as being a radiologist to be able to share some information with you guys. Jürgen, it's been quite some time since you left Bern, but you are the one who kind of initiated all the journey here. As you can see, there are several topics on CSF that have been already touched, and I think this webinar underlines that there's still a lot of information that has not been said, and you're more than welcome to look for these webinars online. And Jürgen is the person who is the head of the CSF section at EANS, and thank you very much for pushing this field, which is very important. So I will give a brief introduction about SIH and briefly touch brain imaging, and then focus on the CSF venous fistula part of the disease, and talk about the transvenous approach, how to treat these, before handing over to Wouter Schieving, who is going to talk about the surgical aspects of the disease. So I'm pretty sure that you all heard about it. So this is patients that predominantly present with orthostatic headache when they come in the early acute phase. Later on in the later phase or chronic phase, the symptoms might be less apparent or less typical. They might have end of day headache or other types of headaches. So it's not a benign disease. I think there are several aspects of the disease which are not benign at all. Wouter has published on several aspects of the disease which drastically impair the quality of life in these patients. And as you can see in one of these publications from Jürgen's group, the duration of sick leave in these patients is substantial. You see that some patients are on sick leave for 2-3 months or more, And as you can see, there is a severe influence on partnership and on social life activities in these patients. So it's not a disease to be neglected. The underlying problem is always at the level of the spine, and there is a discrepancy. So we have a loss of CSF. So the very well balanced system of CSF, the resorption and secretion is tipped off, and this is the underlying problem. What do you see on brain imaging? Just to briefly touch that. So we have three qualitative signs. So these would be the subdural collections. This would be the subdural enhancement, and the rounded sinuses, as you can see here. And then we have the brain sac. So we have the suprasellar cistern, the mamellopontine distance, or the prepontine cistern, which are decreased in these patients because the brain sac is reflected by these measurements. We try to summarize this in a score, the brain SIH score, and patients with a low score, the probability of them having an underlying CSF is low, especially when you have patients in the acute phase. And when you see a patient in a chronic phase, some of them might actually present with a low score. However, in the acute phase, most patients will have a high score, 5 and above. So now today we're focusing on one specific type, on CSF-venous fistula. So it's the third pathology here. However, I think it's important to have in mind that this is just one underlying pathology, and patients with SIH might have other types. So there are the osseous spurs, so there are small protrusions from the disc, which are actually penetrating the dura. And as you can see in this mapped view, you have efflux of CSF into the epidural compartment. So this would be usually called a type 1 leak. Usually those osseous spurs are very small and tiny, and me being a radiologist, I can tell you that we would not necessarily report those spurs in a normal report. However, in these patients, they are the culprit lesion which actually cause the leak. This is one of the biggest spurs I've seen. However, as you can see, usually they're just very small and tiny. On the other hand, the second one is a nerve root diverticulum, which are protrusions. This is probably arachnoid membranes that are protruding through the axilla of a nerve root sleeve. And as you can see, this is a very abnormal looking diverticulum, and there is an efflux of CSF into the epidural compartment. So just these two were just to provide a full picture of the disease, and we will not be touching them further. But the third one we're actually most interested about are the so-called CSF-venous fistulas. These are abnormal connections between the intrathecal compartment and a vein, a paraspinal vein, and there's a continuous efflux of CSF, or on myelography, we can nicely depict those as tubular structures. Actually, just to mention that, Wouter, you're actually celebrating the 10th anniversary, because it's basically 10 years ago since the first time these pathologies were mentioned, and you were the one who actually discovered them. So there is incredible knowledge since then that we have gathered, but you are the one who actually tipped off the entire journey on CSF venous fistula and SIH overall. So what are CSF venous fistulas? We all know granulations which are to be found in the transverse sinus or sigmoid sinus, which drain the CSF. There are similar structures to be found on nerve root cysts. So these are the spinal arachnoid granulations. And we believe, or this is one possible etiology, that there is a increased CSF resorption through those spinal arachnoid granulations. We are not 100% sure if this is a rupture or enlargement of these. However, this is probably the location where CSF venous fistula occur. So around the nerve root cyst, that's where we usually tend to find them. The caveat here, we have an efflux of CSF into a vein, but we never have the blood that's coming actually into the CSF compartment. So this is important to mention, that this is just unidirectional, just the CSF getting into the vein. How do we work up these patients? So if we have a patient where we suspect that it is a SIH patient, we ideally have a brain MRI and have a spine MRI. I think the crucial part here is to distinguish that patients with a CSF venous fistula have actually a very normal looking spine MRI. So here, the first three images, what we can see here, this is the dura, this is the dura, and here we have epidural CSF. As likewise here in the sagittal, we see epidural CSF. And this is to be found in patients with type 1 and type 2 leaks. As you can see here, this distinction is very important. So we need to distinguish between the wet leaks, where we have epidural CSF. These would be the spurs and the cysts. And on the other hand, we have the dry leaks, or the ones which actually have a very normal looking spine MRI. And those are the ones with CSF venous fistulas. How do we work out those patients? So we would concentrate on the select negative patients, so the ones where we don't see epidural CSF. And the diagnostic tool that is very important here is a imaging modality which will show you the efflux of CSF. There are several variations of the techniques depending how your neuroradiologists work. Usually the patients are placed in lateral decubitus, and during infusion of CSF into the intrathecal compartment, there is a gradient, so the contrast is freely flowing the cranial wards, and while this is happening, we are scanning the patient. So the technique that is a lot of times being used is the digital subtraction myelogram, being very careful that we see the contrast in the lateral gutter of the intrathecal compartment. Likewise, a technique as demonstrated here is a CT in lateral decubitus, which has a very good spatial resolution, lacking maybe the temporal resolution of a digital subtraction myelogram. So what do we see? These are digital subtraction myelography images where we see that the contrast is sending flowing cranial wards, and we are looking for suspicious looking tubular structures representing CSF venous fistula. Just to give you one example, these might be very subtle findings. As you can see here, the patient is lateral decubitus. You can see flushing up of a tubular structure here now and there. So why does it disappear? So it's actually here. It comes and goes. So as the patient takes a deep breath, there is a change of intravenous pressure, and there's efflux of CSF into the azygous vein, and that's when the contrast is being washed out. So as you can see, this image is really blown up, it's macked up. So these are very subtle findings where you need to be very careful about inspecting these patients. Nowadays, there are different variations of the technique. I will not go into detail there, but these are beautiful images from Freiburg, from Jürgen Beck and Nicholas Lützen, which really shows the nice angio architecture of those draining veins. And here there is definitely a tremendous advancement in diagnostic techniques over the last 10 years since the first description by Wouter Schieving. But still, we are trying to figure out the best possible setup to improve the diagnostic yield in all those patients. And before coming to, so what are the techniques to take care or treat patients with CSF venous fistulas? So I think it's important to say that the topics or the treatment modalities we're going to be talking the most about are the one here, surgery and embolization. However, there is usually some techniques or some treatments that have been performed before. Caffeine, although it sounds good and usually tastes very fine, there is no permanent relief in patients with clear CSF leaks. A untargeted blood patch is also very unlikely to provide long-term relief because the CSF fistula will probably not be obliterated. The possibilities of a CT-guided local injection around the nerve root, where several groups have reported good results. And then there is the possibility of surgery or CSF venous embo. So for the CSF venous fistula embolization, the technique has been proposed by Walid Brinjiki. Incredible work that he has done here on this topic. It's about 4 or 5 years ago where the technique has first been proposed, and since then a lot of patients have been treated by this means. From a technical point, from an endovascular level, there are a lot of ways how to get to different levels to reach the foraminal vein that is draining the fistula. As we have gotten along, there were a lot of difficult illustrations how to get to a specific level. But by now we have found out, thanks also to Walid, that a lot of the easiest time is actually to access the epidural plexus and then ascend and exit at the correct level, or descend and exit at the correct level. So actually the epidural compartment is your friend while navigating and reaching the correct level. So for to just show you some images how what we see in the angio suite, there is a diagnostic catheter which is advanced in the azygos and hemiazygos system, and then from there on you use a small microcatheter. You do a venogram. You look at the levels here. You see the foraminal veins. You see the epidural plexus here, and from there on you're able to navigate your microcatheter into the desired position. This would be the goal of a treatment where you wanna, this is a lateral projection. So this is actually the neuroforamen here. This is the nerve root, and around that you have onyx cast or a cast of liquid embolic embolizing those veins. This is a final exam where you can see that the onyx in green, how it has it's surrounding the cyst that was draining the CSF venous fistula. Just to provide an example, so the baseline imaging showing all classical signs of CSF leak, and after transvenous embolization, we see basically a normal brain MRI. Thus, the transvenous approach work. There are several working groups which have reported promising results. This is Walid's group himself, which reported a significant decrease from several parameters, so like brain imaging, also clinical parameters, which have improved after treatment. This is another group from Montpellier, from Federico Cagnazzo, which have also reported a similar results in those patients. There are some pros and cons for transvenous, for sure. It's usually a short procedure with a low complication rate, which can be performed in local anesthesia. However, because of onyx being painful, we usually perform in general anesthesia. And it is also possible to perform the embolization of appendicular roots, so the eloquent roots that cannot be clipped. The downsides, probably, there is a poor imaging quality of follow-up images if the patients are to be worked up again because of the embolic agent itself, which is leading to important artifacts, beam hardening artifacts, as in this patient, where after embolization, a previous embolization, and the patient having recurrent symptoms, your imaging quality is very much limited. Having said that, there is a new development of new embolic agents where there is a progressive opacity loss. So a patient having had a embolization in the posterior fossa 4 or 5 weeks later, there is a complete progressive loss of opacity. So there is also development there, which might allow us to better work up these patients in the future. Does CSF venous fistula embolization always work? No. There are patients where there is an incompleted treatment of a fistula. However, it's also important to say that fistulas may evolve or may be found or on new levels after complete treatment of a fistula. And there might be other reasons for headache in SIH patients. I would skip those and come to an end. I think it's very important to spread the word about SIH overall, to keep that on your differential when seeing patient in your clinics. And I think this webinar is just an excellent possibility to do so. It's important to say that CSF venous fistula is one possible pathology why SIH might occur, but there are others, and it's important to keep those in mind. The spine MRI is a very important diagnostic tool to differentiate between the wet and the dry leaks. Dry leaks being the CSF venous fistula without CSF in the epidural compartment. And I think this is very important to differentiate between the different pathologies, because different treatment approach should be applied according to the pathology you're faced with. And there are different techniques to treat CSF venous fistula. And bringing back the patient after treatment seems very important to evaluate the success of the treatment and to look for incomplete treatment or recurrence of a CSF venous fistula at a different level. So again, thank you very much. I wanted to especially thank Eike Pichowiak, who's working with me here in Bern, Jürgen, who has brought me on this journey, and a lot of people who are in this picture who are just bringing the field forward. And thank you, Wouter, and I'm happy to hand over to you.
Thank you so much, Thomas, for this brilliant talk and the overview with specific treatment modalities for CSF venous fistulas. I would like to encourage the audience. We have 100 people watching live to enter questions in the Q&A box. We will read them loud and discuss them. And for the moment, thank you so much, Thomas. I would like to hand over to our next speaker, to Professor Wouter Schiebing from Los Angeles. Dr. Schiebing is from Amsterdam, the Netherlands, and then he went to 2 prestigious institutions after finishing his med school in Amsterdam, to the Mayo Clinic in Rochester, and after that for a fellowship at the Barrow Neurological Institute in Phoenix, Arizona, and was appointed a professor of neurosurgery and the director of microvascular neurosurgery at the Cedars-Sinai in Los Angeles. But apart from that, he is really, Wouter Schiebing is the luminary in the CSF field. And he also brought me into this field by his wonderful publications. He is treating CSF leak patients since 1991. And he is really the luminary and kind of godfather from the neurosurgical point of view for CSF venous fistulas of all types. And then again, 10 years ago, he was the first to discover CSF venous fistulas as another type of leak apart from type 1 and type 2 leaks, and probably some rare, even more complicated leak types. So it's my pleasure to hand over to Wouter Schiebing to give him the word and to focus now on the neurosurgical treatment and your journey about the CSF venous fistulas. Wouter, please.
Thank you, Jürgen. I really enjoyed your talk, Thomas. I'll try to really talk mostly about the surgery for these fistulas. Um, I'm a neurosurgeon in Los Angeles. I've been really lucky because ever since we started our program here, now almost 25 years ago, I've been working with this incredible group of other physicians, mostly the radiologist, the anesthesiologist, and then also, of course, the neurologist. So I've been really lucky. We talk about these type of patients, 2, 3, 4, 10 times a day. What I think, is important to realize, when I saw my first patient with a leak back in 1991, right, back then it was really thought to be something super rare. Now, some studies have come out, one from Beverly Hills here, one from Minnesota. These are almost like totally different type of populations, but incredibly, the incidence that we found is almost identical. It's almost a little eerie. Now, what that means, right? So it's about 4 per 100,000 per year. So that means it's more common than, let's say, multiple sclerosis. It's more common than pseudotumor. It's more common than bacterial meningitis. It's about as common as trigeminal neuralgia. And it means that in Europe, right, all those, I don't even know how many countries Europe has now, but almost 30,000 new patients a year should suffer from spontaneous intracranial hypotension. So that's quite a big number. And of course, we all know about headache. And I think sometimes what we have done in the past, and myself included, and it's a bit of a mistake, we say, oh, look, out of however many patients, 93% had orthostatic headaches. But that doesn't necessarily mean that they have those at the time that you see them in your office or in the ER, right? It just means they have a history of a headache that's much better lying down. But just like what Thomas talked about earlier, oftentimes with the passage of time, that sort of orthostatic component can diminish or even, completely disappear. We came up with this mnemonic seeps a while back, and there have been some more MRI findings that have become clear over the years. And what I think is really important to realize that a lot of these findings that you have in SAH, right, they're completely reversible. So, and then some of those, you can see that within like 3-4 hours after surgery to fix the leak. So one of them are subdural hematomas. Usually that's bilateral, not always. Then there's dural enhancement, is really just enlargement of the veins in the subdural zone. You can get engorgement of cortical veins or venous sinuses. Pituitary can look really large, and some patients have had pituitary surgery. Sagging of the brain is a very common finding that can look like a Chiari malformation. And still, right, even in 2024, I've seen quite a few patients who then get a Chiari decompression with the mistaken assumption that it's a true Chiari malformation. And then, and this is something that Jürgen has worked on for a long time, when you have a spinal fluid leak, the space around the optic nerve becomes really small, and sometimes there's a complete void of any type of CSF surrounding the optic nerve. What I don't want people to think, people who listen to this webinar, is that when you have a patient with SAH, and that's something that's really difficult to treat, right? Or Dr. Dobrocki showed you all these beautiful scans, that these patients need to be sent to a CSF leak center. I think that's really a big mistake. I think if you have a patient that you suspect of having a CSF leak, you just get a brain MRI. I think everybody should get a brain MRI. If that shows the typical findings, a high Beck score, burn score, then you can be really confident that that person has a CSF leak. We always look at the spine because, when somebody puts a needle in the spine, you kind of want to know where that needle goes to. We use what's called MR myelography, but it does not include intrathecal administration of gadolinium. It's just a heavily T2 weighted MRI scan. And it's actually a little better than a regular CT myelogram. And then we perform epidural blood patches, right? Even if it's a CSF venous fistula. If it's somebody who we see early on, somebody who comes in through the ER within a few days or weeks of the onset, we just do blood patching. So early on, you don't need to find out exactly what type of leak it is, where the leak is, and you don't need to send it to a CSF leak center, unless you don't really want to deal with these patients, of course. Dr. Dubravka already went over the different types. This is like really the prototypical surgical type that we're not going to talk about, but it's the leak in front of the spinal cord, ventral leak, almost always from a calcification, a bone spur, osteophyte, or whatnot. If these kind of leaks have been going on for more than a few months, let's say 1 or 2 months, all of these patients need surgery. You also can get a spontaneous rent on the side of the spinal cord. That's usually not associated with a piece of bone. It's more of a congenital sort of weakness of the dura. And then, of course, there are a lot of patients who have these meningeal diverticula or dural ectasia. So we'll talk about the CSF venous fistula. This is just a picture of what that typically looks like under the microscope. So to treat these patients surgically, it's really a very straightforward operation, right? It's very low risk. There are some nuances to it, but it's a very simple, straightforward operation. It really just involves a small foraminotomy that you can see here. Nowadays, through the work of Jürgen and Eric Messicott in Canada, a lot of us now do this through the tube, minimally invasive spine surgery. Here, people still spend a night in the hospital. They go home the next day. But that's what it looks like under the microscope. So on the top there, you see the common thecal sac. Then there are a few little cysts, meningeal diverticula. And there's the vein that's basically just sucking out the spinal fluid. Dr. Dubravka was right. It's been now over 10 years ago. And yes, we may have been the first people to describe it, but it was a totally fortuitous finding. We were not looking for a fistula. We just happened to find it when we did myelography, looking for different types of leak. If you, and I should really point this out again. So for CSF venous fistulas, these are patients who have no CSF outside of the dural sac. Some people call that a slack, but it doesn't have to be, all over the spine, right? You can get a dural tear with a very confined small area of extradural CSF. So we usually don't use slack. I just talk about extradural CSF, but if there's no extradural CSF and somebody has SAH, then with current technology, you can find a CSF venous fistula about 75% of the time. If you have a normal brain MRI, but symptoms of a CSF leak, mostly orthostatic headaches, we find a fistula about 10% of the time. But of course, that really depends on, where you get your patients from, right? If they're all from really good headache doctors, the yield is going to go up. If you, pretty much do a myelogram on anybody with any type of improvement after lying down, then your yield is really going to go much, much lower. Then there's a specific group of people who have frontotemporal dementia symptoms and really severe brain sagging. Unfortunately, in those people, they hardly ever have extradural CSF, and we're able to find a fistula in less than 50% of those patients. So Thomas already talked about, if it's a ruptured arachnoid granulation. I think that probably is the case, but we don't really know. There really are different types of fistulas that we'll go over a little bit. Sometimes they're associated with venous or venolymphatic congenital malformations. They can be at any spinal level, really, but definitely most common in the thoracic spine. And about 1 out of 10 patients have more than one CSF venous fistula. These are just some pictures of DSMs that show the fistulas. The one on the left are in the thoracic spine. They're associated with a meningeal diverticulum. It's not always the largest one. As a matter of fact, it's the largest one only about 1 out of 3 times. But you also can get these fistulas, without a meningeal diverticulum. as you can see on the DSMs on the right-hand side. Up until about 3-4 years ago, we really only found these fistulas in the thoracic spine, mostly because we didn't really focus on the cervical spine or lumbosacral spine. But you can also see them in the cervical spine, you can see them in the lumbar spine, and you also can see them in the sacrum. So they really can exist anywhere along the spinal axis. And then these are some intraoperative pictures of what these fistulas look like. The arrows just show the point between the CSF space and the venous connection. And they all look pretty similar, but not quite identical. And then once in a while, I'll resect the area between the dura and the venous system, but it hasn't really brought us any closer to what exactly is the cause of these fistulas. You really have, for the surgeon, I think it's important to realize there are really 3 different types of fistulas, right? So most commonly, about 80% of the time, these fistulas are really distal along the nerve root sleeve. And with a simple foraminotomy, you do not see those fistulas, right? But you direct your attention to the proximal nerve root sleeve. About 1 out of 10 times, you do recognize the fistula at the time of your foraminotomy. So it's really proximal along the nerve root sleeve. And then about 10% of the time, we find that it's not related to a diverticulum of the nerve root sleeve, but it just appears from the common thecal sac. But in those patients, there usually is a tiny little diverticulum coming off the common thecal sac. And then, interestingly, what we found out over the last few years, that sometimes these fistulas can be associated with these venous malformations. And that's been described now by quite a few groups. This was a teenage girl who'd been in the hospital somewhere in a different city for a month. She was not able to get out of bed. She was born with this extensive venolymphatic malformation that involved her buttock and the sacrum, as you can see here on the sagittal MRI scans. And then the DSM on the right side shows that there's a CSF venous fistula going into this venous malformation. Marcel Maya, who's the interventional neuroradiologist I work with, he was not able to navigate through this extensive vascular malformation. So I decided to operate on this, and by the time we had exposed the bone, she already had lost about 800 milliliters of blood. So I aborted the surgery, and then Marcel was able to actually cure this fistula just with direct punctures of the vascular malformation around the site of the fistula. So sometimes these are really difficult to treat. This is a gentleman in his 50s who'd been suffering with orthostatic headaches for quite a while. He has this syndrome called the blue rubber bleb nevus syndrome. He's got these little vascular malformations of his tongue, his GI tract, the bottom of his feet. He was known to have meningeal enhancement for all this time, and he has a whole bunch of different vascular malformations in his body. These are the ones at the cervico-thoracic junction. You can see that there are multiple sites. It was attempted to embolize, wasn't able to embolize them, so he underwent surgery. This is a lady in her 60s who'd been suffering with orthostatic headaches since she was in her 30s. And also she was diagnosed, as you can see in that second picture, with a arteriovenous malformation of her cervical spine. And she had had many angiograms that did not show that. So her diagnosis was an angiographically occult AVM. She'd undergone 3 surgeries. As a matter of fact, I operated on her when I was a fellow in the 1990s. But we just found normal blood vessels. Then she finally was diagnosed with this vascular malformation just outside of the foramen. Also was not able to be embolized, so she just underwent clipping of that nerve root sleeve, went home the next day. As you can see on this post-op MRI scan, her cervical AVM completely disappeared because it's not an AVM, they're just dilated blood vessels within the dural sac. We'll skip this one. Well, this is also somebody I operated on. A lot of blood loss. So then Marcel luckily was able to embolize it. This was a young woman who has this vascular veno-lymphatic malformation within the spinal canal. So the other ones were really outside of the spinal canal. Luckily, we were able to treat that with multiple embolizations and injections into the vascular malformation. And you can see there the arrow points to a new fistula that arose after partial treatment. So there really are three main ways to treat fistulas, right? So, and that's outside of blood patches. So usually these patients come in pretty late because by the time the fistula is diagnosed, you know, many months, if not years or decades have passed. So then we skip blood patching. The first 10 patients or so who we diagnosed with CSF-venous fistula 10 years ago, we did percutaneous fibrin glue. We were very unsuccessful in that. So we don't do that anymore. There are some groups like Dr. Carlton Jones in the UK and Mark Mamelouk in California who have really good results with percutaneous fibrin glue injections. We just have not been able to accomplish that ourselves. Then there is the onyx embolization that Thomas talked about. We do that with general anesthesia. In our hands, the cure rate of that is about 70 to 80%. So that's really high, but not as high as surgery, right? So if you do surgery for these fistulas, you really kind of have to scratch your head, right, if the surgery is not successful. And I think, you know, the failure rate of surgery should really hover around, you know, 1, maybe 2%. Some people, you know, I don't think anybody here, they actually divide the nerve root. I don't think that's really necessary. You don't need to do that. Just simple placement of an aneurysm clip. So what do we usually do at Cedars when we suspect somebody of a CSF venous fistula? We get these non-invasive imaging scans. When it's confirmed that there is SIH and there's no extradural CSF, we just go straight to lateral decubitus digital subtraction myelograms. Because prone myelograms, we didn't really talk about that so much, prone myelograms have a really low yield of finding these fistulas. One option for surgery is to actually identify the fistula, as you can see here, and you can place an aneurysm clip on it, or you can just cauterize it. If it's a non-eloquent, non-functional, so to speak, nerve root, then you can clip the nerve root sleeve. Like I said, some people divide the nerve root. That's not necessary. Also, it doesn't sound so good when you talk to the patient, right? Like you say, well, we divided the nerve root. It doesn't really make that much sense. And I think, indeed, that if you just place a clip on it, then there's a good chance that you'll preserve nerve root function. Some neurosurgeons are somewhat nervous, and, you know, rightly so, of course, if they feel that the artery of Adamkowitz is near or at the site of the fistula. I've done about more than 750 nerve root clippings of the thoracic spine. Some of those, the majority of those actually were before we discovered fistulas, because then I would clip, you know, 2, 3, 4, you know, up to 10 thoracic nerve roots when there were meningeal diverticula on it. And I haven't had any patient who had any type of motor deficit. Doesn't mean that it cannot happen, but it's really rare. What are the other consequences of ligating, clip ligation of the nerve root? And Dr. Beck's group just came out with this publication, I think this week. And they found that some numbness along the distribution of the nerve root is really common, right? So there were 40 patients who had nerve root, thoracic nerve root clip ligated, 83% reported at least transient numbness. That's usually really well tolerated. People usually don't consider that a major type of consequence. little bit different is neuropathic pain. Of course, that's usually easily treated with medication, but not always. That happens about 5% of the time. Another consequence that I wasn't really aware of, hasn't really happened until we did maybe the first 100 or so surgeries for CSF venous fistulas, and that's loss of motor function of the subcostal or intercostal muscles. And this happens sometimes within days or weeks of the surgery. And the patient will see a general surgeon. They're diagnosed with a hernia. I've had one patient who had exploratory laparotomy for that. There was no hernia, but then unfortunately there was a tear, iatrogenic tear, and then the patient was in the hospital for 2 weeks. So if you see that, you should tell your patients about it, of course, what to expect sometimes. But it's, you have to tell the general surgeon, hey, don't operate on this. So the preferred treatment really goes about the patient preference, right? So some patients just want to get it over and done with, then we usually recommend surgery. Some people say, oh, there's a great method, possibly avoiding surgery, 70–80% successful. In other places, maybe even higher. But if it's a functional nerve root, I always tell patients that I feel very strongly that they should undergo embolization. Also, if it's a vascular malformation on your way in for surgery towards the fistula, I recommend embolization if at all possible. So this is just somebody we saw recently who's got this pretty extensive CSF venous fistula at 3 levels of the cervical spine. So we did embolization. That was not effective, so the patient did undergo surgery. And onyx under the microscope looks kind of pretty. Kind of looks like working through a silver mine that you can see on that middle picture there. But you also have to be a little bit careful because onyx really conducts electricity well. So be sure, not to get your bipolar near it. And then, of course, if you do that in the cervical spine, you have to do facetectomies, fusions. It becomes a much more invasive type of surgery. So again, right, we think it's caused by a ruptured arachnoid granulation into a pre-existing vein. That can arise from the nerve root sleeve, sometimes from the common thecal sac. You can have associated vascular malformations, usually in the thoracic spine, but not always. 10% of the time, there's more than one fistula. There are 3 really good treatment options. And of course, if you want to know more about these and other types of CSF leaks, we're going to have our next SIH symposium in Amsterdam the last weekend of June of 2025. All right, thank you very much.
Brilliant. Thank you so much, Wouter. Thank you so much, Thomas. Fascinating, interesting talks. And please, again, type in your questions in the Q&A box. And I will start giving you, Thomas and Wouter, giving you the questions from the audience. And probably we start with some easy technical ones. Thomas, for you, do you perform DSA myelography for SLAC-positive patients? What is your maximum volume of contrast agent for DSA myelography?
So let me unmute yourself. So in the beginning, I would say we were a little bit more careful and usually only use 10 cc. Honestly, even using 15 and up to 20 have extreme low rate of complications. We have maybe within the last 10 years had 2 epileptic seizures. So the rate is very low, even with using up to 20, but we try to keep it between 10 and 15.
And another one asks, what type of catheter do you use for the Asicus vein? Another technical question.
So I would say that from an endovascular point, there is a lot more challenging anatomy when going intracranial, where the choice of the catheter, distal catheter, is a lot more crucial for CSF venous embolization. the choices open up to you. A lot of times we start with a 5 French diagnostic catheter, placing in the azygos vein, and then through that use a long microcatheter and then use it for embolization. However, there are variations to the technique. Some did use balloons, some did use pressure cooker type of embolization. So there are variations, but usually a simple setup with a microcatheter works fairly good.
Mm-hmm. Then there is one very interesting question from Alvaro. Walter, you touched briefly on the pathophysiology of these CSF-venous fistulas. We are not really sure how they evolve, what's the real origin, and probably they arise also suddenly. And there's a question related to this. Is there any causal association between intracranial hypertension or hydrocephalus and the development of a CSF venous fistula from the UK?
Yeah, that's a great question that we've been struggling with to really have a scientific basis to say yes or no. So I think, we've all seen patients who have been diagnosed with pseudotumor 20, 30 years ago and then develop a CSF venous fistula. We've treated people with, BMIs over 50 who have an opening pressure of up to 48 centimeters of CSF who develop a CSF venous fistula. So you'd think that probably is a causative factor, but nobody's actually ever, proven that in any way. But there's Harold Recate is a pediatric neurosurgeon who I met when I was in Phoenix, and he has told me over the last 20, 30 years that it really doesn't make sense to fix these leaks, because you fix one, the pressure builds up, and then the patient will develop another one. I think that happens occasionally, not that frequently, but that certainly is something that people have been thinking about for a really, really long time.
Yeah, we do have the same impression, I think, in Bern as well as in Freiburg, that there are probably a subgroup of patients with CSF venous fistulas that arise from a constant high pressure in the system, but there is no proof of that. And there's one important issue, I think, Walter, you emphasized that SIH is not so rare as we all might think, but on the other hand, there is no need to come immediately to a CSF center. And first of all, do an MRI and do a blood patch. I think this is a very important message. And a blood patch, I don't know how many thousands you have done or we have done, is really, the cost-benefit ratio is extremely well, and there are hardly any severe side effects of a blood patch. So do a blood patch. But on the other hand, I believe, and I'm expecting your opinion, Marta, I do believe that it is very important not to let this disease come to a chronic state, because you also mentioned it, that at one point, if your blood patching doesn't do any good for your patient, there might be very well the point where you say, okay, now let's approach a CSF center to localize the leak, to diagnose the leak, to do specific imaging, because we all know that after 3 months or even after a year of having SIH, it's really getting more difficult for us to heal our patients. What do you think?
Yeah, I mean, you're absolutely right? And you have shown that in several publications now, that treating it early, or maybe not treating it early, but fixing it early, has a really tremendous impact on the chance of success. But I think that's part of why I say don't immediately go to a CSF leak center, because there will inevitably be some delay. So you go with your blood patch, great, right? You'll know within a few weeks if that's successful or not. That's not wasting too much time. And then if that's successful, great. But if not, then think about a referral.
Okay, excellent. And also the modifiable risk factors in Lalani, Carlton-Jones' work, and also Brechicki's work is timing. Timing is a modifiable risk factor, but we're speaking about months and years now. So don't delay the specific treatment after you've done a first blood patch. Thomas, Thomas, do you also agree?
I'm completely in on that, and the too much of a delay is not good, and we try to bring our patients back usually 4 to 6 weeks after any kind of treatment, should it be for the ventral leaks, but also for CSF venous fistula, to see if there is any evolution. And actually, it's very good to pick them up, because in several of those patients you can see there was an improvement after treatment, for example, after embolization, but then it got worse again. And we have had several of those where we picked up new fistulas at different levels. Maybe if I can ask you, Wouter, you mentioned that there was a success, and I think when you clip a nerve root that was the culprit one that was leaking. So, and also for us from the endovascular point, so how can we actually say that in those patients and that our treatment was successful? Because if there's a clip, if there is onyx, it's hard to see if there is any residual flow. We usually don't bring the patients back for a myelography. And if the brain MRI was not as suspicious, the clinical findings were not so specific, how can we actually evaluate the success of any kind of treatment? So what's your what's your parameter to evaluate the success in these cases?
Sure. Well, when I talk about the 1% failure rate, I really talk about radiographic failure rate. Right, we're pretty aggressive in repeating DSMs after treatment, right? Whether that's embolization or clipping. The clip artifact is really minimal, right? So if you have an obvious fistula and that's not visible anymore after clipping, that is a radiographic success. With embolization, that's a little bit different, right? But you kind of just have to compare the extent of the fistula, what it looked like before the embolization, and compare it to what it was like after the embolization. And if it's sort of a, a definite but somewhat difficult to see fistula, then then I don't know if that fistula is still there. We usually have a pretty low threshold for going ahead with surgery if a person has failed embolization, even if we don't see it anymore on follow-up myelography.
Mm-hmm. So
If
you
I,
would, mm-hmm.
Mhm.
So
Thomas?
you would go ahead, despite not seeing it anymore or not being able to demonstrate it again. You are very keen on doing that an open approach and clip that level.
Yeah,
Mm-hmm.
right. Just because the risk is low and the potential benefit is exceedingly high.
Mm-hmm.
One thing I might want to add, Thomas, is of course you do not regularly schedule your patients for a redo invasive angio or DSM if everything is fine, but please, this is very important to follow these patients. It's not okay anymore, as it has been done in decades ago, that you do a blood patch. All patients are fine the next day after a blood patch, and then discharge the patient cured. You need to see them clinically after 6 weeks or 3 months, or need to do a follow-up via email or prompts to see how they are doing, if they are back to life, back in their job. And this is really important to follow these patients. We do not really know a lot about the disease in general, so it's really important to follow the patients. Then another technical question, this time for the surgeons. When would you choose to clip a fistula versus cauterizing it? Wouter, to you.
Well, I think what I like about clipping is that if something would happen in the future, right? Let's say you're in that 1% where it was not successful, or something might happen later on. I like putting clips, right? Whether it's for an AVM, for anything, just so you have a nice marker for any type of potential follow-up studies. Otherwise, I think it's totally fine to just cauterize the fistula and ligate it. You don't need to clip it.
But probably it's also a reason why surgery is better than embolization, because we probably clip out potential new sites at the same site. Do you think this could be a mechanism? This is my impression, that why are we better doing surgery than embolization in these lesions? Because probably a clip is more permanent and can even prevent a new fistula in this diseased nerve root. Is this a valid thought, or what do you think?
Yeah, I think you're probably right. And of course, I've shown pictures of like a single fistulous connection, but I think quite a few people now have shown that oftentimes it's multiple fistulous connections, and just by getting rid of one of them, that might not be enough.
My question from my side: what do you think is actually more frequent, to seeing a fistula at the same level, or actually seeing a fistula, on a different level in a patient who initially gets better after treatment and then or doesn't get better? What do you think the overall rate is? So is it more frequent to see new fistulas at different levels?
Well, for people we have operated on who have a recurrence of symptoms, it's much more common that it's a fistula at a different level rather than the same level.
Mhm.
Another short question. How many CSF fistulas are associated with venous malformations? Maybe I missed it. Could you repeat, please, Walter or Thomas?
How
How many fistulas are associated with venous malformations? Is there a number in the literature? Walter, you showed a lot of these venal lymphatic malformations. Is this rare, or is this common, if you don't have a number?
I think it's rare, but a lot of it is just a lot of referral bias, right? So it's really hard to tell. I'd say the vast majority of people we've seen with these vascular malformations were from outside of California. So I think it's rare.
Okay. Are there any reports of intracranial CSF venous fistulas? Not spinal ones, intracranial CSF venous fistulas.
Yeah, we've seen one young boy who had a traumatic CSF venous fistula in the lower clivus, and he actually presented with brain sagging. We've had another 13-year-old boy who had a CSF venous fistula through a defect at the level of the porus in the posterior fossa. And then we just operated on a 8-year-old girl who had a CSF venous fistula at the level of the sigmoid plate between the jugular bulb and the carotid. So, it can happen, but it's, also, I think, really rare.
Okay.
Definitely 99.99% of the time when somebody has SIH, right, the leak is at the level of the spine.
Okay, thanks for clarifying that. Then a question that very often arises: how long do you wait after a first blood patch? Either for repeating a blood patch, for seeing the patient again, or for transferring the patient into a center. How long do you wait after the first blood patch?
Well,
Walter, this is for you. You have the most experience. Yeah, the most experience.
Well, we had a rule. We had a rule for a long time that we would not repeat blood patches within 5 days of the first blood patch. But that was really just based on a single patient who had paraparesis after his second blood patch that was done within 3 days. I mean, I was going to take the patient to the OR to remove the epidural blood patch, but by the time he got out of the MRI scanner, his exam was normal. So it really depends, right? So if you have a comatose patient and you do a blood patch and they're, not any better, and you don't have any other type of treatment, then you can, repeat it 24 hours later. But in general, and also, of course, it depends on, the type of leak. But we usually give it 2 weeks for a blood patch to work. So if we do a blood patch and they're really not any better in 2 weeks, then I say, well, it's not going to work.
Okay, we do the same. Probably I have this from your center. We roughly say 2 weeks is enough as the test time for a blood patch to be efficient or not. Thomas, do you also use 2 weeks or?
So honestly, yes, if we go by the books, we do. However, in some leak types, as a clear type 1 leak with large spurs, we also tell the patient that the blood patch is very unlikely to provide long-term relief and also go straight to surgery. So in type 1 and type 2 leaks.
Okay. Then another question that is quite common, the stopping rule. When do you stop? When do you stop repeating myelograms, repeating DSMs if you have a high suspicion for the patient being a leaker? When do you stop if the examinations are negative? Is there any rule of thumb when to stop?
Do you want to
Thomas?
get it? Well, I think.
Yeah, I think one good rule is if you have somebody with a MRI scan that clearly shows that the person must still be leaking, then we don't have a hard stop, right? I think the most DSMs we've done on a single patient was 10 DSMs. But these are invasive tests, right? It's a lot of lumbar puncture, so kind of depends, right? I oftentimes will talk with the referring headache doctor. If the scan is normal, right, brain MRI is normal or has become normal, because then of course at some point you should stop. Certainly, if there's a possible other reason for their symptoms.
One more question from the audience. Yeah, Thomas, you first.
No, so I completely agree that in patients when there is clear signs of a leak, I think it's easier to push and go further. I think the difficult group is the ones where you don't have clear signs of a leak. Brain imaging signs, especially when the patients are presenting not in a very delayed fashion, and you don't see anything, or even if to bring them, because if you say the brain MRI is normal, the clinical presentation is not very specific, and the spine MRI doesn't show any cysts. There the question is, how many patients do we have to scan to actually find someone? So if I know that there are reports saying, and your paper, Wouter, was very important in that regard, but if there are no cysts, then I think we are sometimes reluctant to scan those patients, because in your paper, if I'm right, the patients with a low brain score presenting fistula all had suspicious cysts.
That's correct.
So do you bring patients in that don't have any cyst?
Occasionally. Mm-hmm. Yeah, we look at this optic nerve sheath diameter now, right? Based on MRI scanning. And again, right, I mean, you have to have a good conversation with the referring headache specialist, right? Because I'm not a headache specialist. I treat maybe 2 or 3 of the 395 reasons for a headache. So I don't want to pretend that that's my area of expertise.
Another question from the audience. Do you have patients with deterioration of the level of consciousness caused by a large CSF leak? Does this happen?
Yeah, we see that occasionally. It's always associated with, profound brain sagging. But that occasion, not that common though, because we have like a really busy ER. We actually have the busiest ER here in Los Angeles, but we don't see it that often. But it does happen.
Then again, for pathophysiology, why do the CSF venous fistulas have a predilection to occur at the thoracic level rather than the cervical, lumbar, or sacral level? What would be your hypothesis? Thomas Water. Speculate.
So
We don't know.
at least when I was working this up, I mean, Wouter, you're the godfather of CSF venous fistula. But when I was reading all your papers and all the stuff about it, at least I found some animal studies saying that the granulations, those the spinal arachnoid granulations, are actually more prevalent in that area in healthy animals. So I'm wondering if that might be the reason that they're just simply more frequently to be found in that area.
I mean, that's what I think as well. Also, right, because it's been pretty recent that we've been finding, a lot of fistulas in the cervical spine. Because one of the drawbacks of digital myelography is that, it cannot cover the whole spine. So we, up until like 5 years ago, we hardly ever looked there. So I think it's actually not that rare in the cervical spine.
Excellent. So we still have a lot of people watching and listening to us. Any more pertinent questions or statements you want to give? I covered almost all of the questions in the Q&A section. So then, thank you so much to the both of you. It was brilliant, and I've learned a lot. And we need to bring CSF venous fistulas to our mind. And again, Wouter, I told this to you very often. The disease, you found this type of fistula 10 years ago. In Europe, we had a hard time finding our first fistula, and it took us years to believe and to understand. And now it's daily business, daily routine. So don't give up. Look for the CSF venous fistulas. Use techniques Thomas has shown you, Wouter has shown you. And I hope we continue with this fascinating journey. And I can only say that please join us for the Amsterdam meeting. There's a brilliant program, and there's also, I think, the possibility to submit some abstracts. So thank you so much for your talks, for your time, and for the discussion.
Thank you for giving us this chance, and also for this forum of a webinar. I think it's a great possibility to spread the message. Thank you.
Thanks, everyone.
Thank you. Bye-bye. Ciao, ciao.